We're excited today to talk about summer telehealth from a couple of different perspectives. Happy to have Dr. Ruben Rakoba from Pediatrust out of the outskirts of Chicago, Illinois, and Dr. Libby from Virginia Pediatric Group, who will really bring us two different perspectives. So Dr. Libby is working almost 100% virtual, so really has some unique perspective on how to get patients into his virtual care platform and how to get kids connected from his medical home into virtual care. And Dr. Rakoba will talk about Pediatrust and their initiative to get kids that are outside the medical home or even within the medical home from camps and distant sites during summertime to get kids connected to pediatricians. So we'll also talk a little bit about patient engagement. So without further ado, and apologies for the technical difficulties on the start, let's turn it over to Dr. Libby.
Hey, it's good to see everyone virtually, any which way. We have gone through a pretty extraordinary year, starting, I guess, 2020, March, April. Most of us felt like it was the end of our practice world. Things closed down. We had a real tough time dealing with all the changes that we had to implement in our practices, finding protective equipment, et cetera. But somehow we managed to get through it. Certainly telemedicine was a godsend for many of us, certainly got us over a hump that many of us would never have noticed until much later time. And it really did help for our patients, our offices, and provided some significant revenue, but certainly not enough between the changes in everyone's attitude towards, do I see a doctor, do I need to see a doctor, et cetera. As much as we might try to maintain our medical home, we had to rely on that PPP. And, most of us sort of thought, well, I can't wait to get back in the office, excuse me, so that I can practice medicine the way I know I can and the way I'm used to managing my practice and generating the revenue that we need to survive and thrive into the future. Well, I think that many of us haven't really realized that level of return to normalcy yet. Certainly kids aren't as sick as they have been in the past, and we know those trends are going down. And although mental health does make up for some of it, it doesn't make up for all of it. So it's not easy getting back to do the same old thing, but telemedicine is still there, and there are some things we can do to actually provide a better source of care for patients. And we'll talk about those in a couple of minutes. Certainly the summertime is also, the way we generate revenue through checkups and preventive care. And we know how to do that. We get some revenue from some of the things we do that are ancillary to that, whether it's hearing screening, vision screening, doing your scales and testing to do immunizations, you get some margins there. And we're used to understanding how to do that. People want to come into your office. They want to see you there. And, you figure, well, those sick visits and those other kinds of consults I might do sometimes, they should want to come in to see me too. But, you're talking about them coming to your home. You want to be their medical home, but they're at their home and they want your medical home in their home. And so a lot of these things, they're going to say, well, it's not that crucial. We've got other things going on. It's after 5. I'm just going to go to the RBC. I'm going to the urgent care down the street. This is easy. Maybe I'm going to be out of town. I'm going to be visiting the grandparents. I'm going to be traveling, doing a vacation, believe it or not, if we can ever do those again. Or they may be at camp, like you'll hear a little bit about later. So what are we going to do? Do we want to lose these opportunities? We certainly have established our medical home. We know that they've gotten used to having our medical home at their home. And there are great opportunities to capture revenues. And, these are things that we used to give away. So if we can move to the next slide. And one other thing I will add to that, which was something that I think is important too. Prior to COVID, I think that we all were able to offer early morning hours, before work, before school. We had walk-in times, and people use those times to come in and access care. I found now that people are heading more into the late afternoons and evenings. And the place where we can fill up our hours is between 5 and 8. So thinking about that and thinking about where we provide care. If you can do telemedicine from anywhere, you don't have to be in the office. You don't need a whole staff there to support you. You can actually do this where you have broadband and where you can access the internet, and you can create these opportunities for additional revenue. Kids are out there doing things. They're getting, poison ivy, they're having insect bites, whatever it might be. As you see in our summertime options, we have lots of things that we can take care of. And I think most of us got used to taking care of a lot more than we might have anticipated our capabilities or comfort with prior to COVID. So we've learned how to take most of those simple kinds of viral illnesses. Doesn't have to be too sick, but can have a cough and congestion and wants to see you and would call for advice. But now, why not create that opportunity for an encounter? GI issues relative to viruses, constipation, things of that nature. Feeling the belly is about probably 20% of it. It's 80% history. So we know we can do a lot of these things at our telemedicine visits. Chronic care issues, doing consults for ADHD, anxiety, depression, evaluating meds, doing med checks after changing or initiating a new medication, reviewing allergy, asthma type protocols. School year, you can review how things went. There's so many ways that you can set up your practice, and you may need to market it some. You may need to be there at a time when you normally weren't, but you can do it from your vacation home, from your own home, or from the office if that's where you so choose. But telemedicine gives you that flexibility. If you're going to do preventive care, yeah, some people feel uncomfortable with it, but I think as you do it, you get more comfortable. You create the support teams in the office that help you to do it effectively. You create, possibly curbside vaccines to make it even more convenient. And you may have parameters around, you have to come in once a year to get weighed, measured, and physically checked. Sure, that's fine. But there's a lot that you can do this way. And it does provide patients with a great measure of satisfaction to be able to get their visits done without necessarily interrupting or exposing themselves to COVID or anything that they are a little bit nervous about. Next slide. So here we go. We have a pretty good situation here. We have certainly, the whole concept of what we can do while we are trying to stay connected with our patients. We're trying to make it easy for them. We're trying to make it easy for the office. We're trying to create opportunities to sustain that medical home and that revenue for things that patients seek care for. Some people get worried about licensure, and it's something to be aware of. If someone's out of town and accessing your care from someplace you are not licensed, there is a potential liability. When patients are in other locations, that is where the care is considered to be provided, so that you are, let's say, responsible to have some coverage by your malpractice insurer, and sometimes also be dictated by the specific rules and regulations of that state where they are, not necessarily where you are licensed. If you are out of state and they're in the state you are licensed, no problem. But these are things you need to make sure you're comfortable with and you understand. Most malpractice carriers do understand that patients who are in your medical home may go out of state and seek treatment. They will cover you. But you may need to just check and make sure that a telemedicine visit is covered. And it's not unwise to have that awareness. Certainly some states have reciprocity. There is something called the Interstate Compact, which people will sometimes go through to get licensure in other states, but you really need enough patients to make it worth the investment. Nonetheless, it's something you should know. Understand the rules before you play the game. Next slide. So when we talk about summer telehealth, what are the benefits? My God, it's easy, and it's from where you are to where they are. And that's an amazing thing, something we never could conceptualize before, but it does give us this incredible expansion of capability, both in terms of providing good care, sustaining the medical home, and generating the revenue we need to survive as primary care docs. Nobody cares about us much, but we have to care about ourselves, and this is a way to do it. Also, you can create times to connect and reinforce all the issues that you try to sustain through your opportunities with your patients. You can treat acute illnesses, manage acute conditions, and you can really provide quality care and, once again, generate revenue. So this is something that I encourage you to do. Certainly, some people have a hard time. It's still not being in the office. I feel uncomfortable. I don't have a good presence on the screen with them, or whatever it might be. Get used to it. Start to build that repertoire. Understand, patients love this. They want this. And if they feel comfortable with the way you feel about doing this for them, it will be an expansion of your practice. It won't be a reduction. It will give you more opportunities. So how are you going to let your patients know that you want to do this? You want to inform them, personally, if you have an interaction, an opportunity to see them in the office or talk to them through a telemedicine visit, whatever it might be. On your on-hold messaging, most of us do have voicemail features that have on-hold messaging. You can mention there that this is something that you can do. Your website's a great vehicle by which to promote this. Other social media, if you do Facebook, YouTube videos, Twitter, any of those things, that's something that you can reinforce if you've got a good patient following there. And of course, you're going to get some suggestions from Anytime on the kinds of PDFs you can use on your website. A nice page that introduces the summertime access and some of the conditions they might consider having treated. And then, of course, your triage. You can always have your triage remind folks when they're engaged that this is something that is available. So you've got my reinforcement here. I'm the salesman. I'm giving you the pitch, but really, I'm living the life. This has been an important adjunct to our practice. And I feel it's really something that patients value and will enhance the quality of care that we provide and allow us to provide better care in any kind of payer system. So let me move on now and turn the mic back over to Nick or Ruben.
Sorry, I had to unmute myself. You think after 15 months we'd learn, but still doing it. All right. Well, great job, Russell. I want to just reiterate what he said. I'm not sure exactly how many of you have already been using Anytime or have it but haven't been using it very much. We really jumped in with Anytime before the pandemic started, and after the pandemic came, obviously, everybody jumped in. It was tough, like pulling teeth to get some of our physicians to sign on and do telemedicine. And I represent a group that has, 70 different physicians in it. But once the pandemic came, obviously, Anytime was a godsend for us. Telemedicine was a godsend for us. And as Russell said, it helped us keep our doors open. And I will tell you, as somebody who did a lot of telemedicine visits over the last 15, 16 months, we're not putting the toothpaste back in the tube. Patients love it. They really, really like it. And they are going to keep using it. So it's here. The future is here today. So this is going to be part of something that they expect. And if you're not using it now, they're going to find somebody that does. So again, a wholehearted endorsement of telemedicine in general and Anytime in specific. So my task today is to talk to you a little bit about a different sort of initiative that we're using telemedicine for. And it started because last year with the COVID pandemic, many of the summer camps that are close to our area were located in suburban Chicago, as Mick said. Many of the camps that our kids go to, our patients go to, are in just the neighboring states, specifically Wisconsin, Minnesota, Michigan, up in the beautiful North Woods. And many of those camps had to cancel completely. Some of them did an abbreviated version of camp last year, but nobody could have a camp doc on site. These camps usually have parents or volunteers who come in for a week, maybe two, during the 8-week session. And that's how they usually get by. Well, last year that was not happening. So a couple of them reached out to us because of our prior relationship. Either we sent our kids there, or in one case, one of our doctors actually went to that camp when she was young. Um, and they reached out to us and said, could you help us in some way? And so we said, well, we can provide telemedicine services. We're not sending anybody up there, but we could certainly do that. And we did that for a couple of camps on a very limited basis. They were only in session for, 3 or 4 weeks, and talked them through, but they really enjoyed the experience, as did we. But it's word of mouth. It's a very select group, very small group, and they all talk to each other. So the camp directors from those camps talked to a lot of others, and we were able to recruit 12 camps this year. And we decided to go with what we call a concierge model. You can go on to the next slide. Yeah. The concierge services is really a suite of services that we defined for all of the camps. And in exchange for that, they would give us a weekly, really a monthly charge, as well as the ability to charge insurance for each of the telemedicine visits that we do and any tests that are performed. So there is some revenue, but even if we only have a smattering of visits, we're still going to make some money on this because of that concierge surcharge. And let me tell you, these kids are paying thousands, or their parents are paying thousands and thousands and thousands of dollars for, for them to go to camp. So adding on, a surcharge, or however the camp handled it, to charge them, or sometimes some of the camps just ate it. Really, nobody batted an eye. I mean, when we told them, we'd like a fee per week, they all said absolutely, because they knew there was no other way that they could get enough doctors up to camp this year. So this was a way, it was a win-win basically for both of us. So the nice thing with the concierge service is the camp is assigned to one of our practices. I should say that PediaTrust is a super group comprised of 12 different in the Chicago suburbs. We would assign one office to the camp, and specifically one lead physician in that office from 9 to 5, Monday through Friday, or 8 to 5. That physician would sort of be the one that was going to handle the vast majority of the telemedicine visits. Overnight, weekends, holidays, then it would be the others in the office. But again, still just one office for them to know, and really one doc in particular. Some of the other services that we provided, not mentioned, I didn't put this down on the slide. We went over an equipment list. These are the things you need to have in camp. Most of them do that every year, but there were a few that took our recommendations and said, oh yeah, we don't have that. That's a good idea. We review their standing orders. We assist with the policy this year, obviously very important, regarding surveillance testing. How are they going to surveil? How frequently are they going to do that? Who's considered okay at what point, and all of that stuff. These camp directors were pretty knowledgeable, but still they needed some fine tuning with some of their plans. We also provided analyzers, the machines to run COVID tests, obviously, and strep tests, and then all the supplies and test kits for that. At the end of the summer, we'll get them back. So we didn't charge them for that. We said, here it is. And then for the test kits, they'll just return whatever kits they don't use, but we will charge the insurance. If the camper does not have insurance that we accept, then the camp is responsible for that, and then they can figure out however they want to either build a camper or the family, or just reach into their pockets and pay it, and so be it. We offered to train their health staff if needed, not only on COVID stuff, but specifically how to use the analyzers that we give them. We talked to parents on a general webinar. A lot of these camps have a webinar 2, 3, 4 weeks before camp, just doing all the information. It's often very long, a couple of hours, and our doc would go on for 15, 20 minutes, whatever it takes, to give a face to a name. This is Dr. So-and-so. She will be the physician who's the lead physician attending to your child, and answer any questions that come up on the webinar. And then offering to talk to or meet with one-on-one through some sort of Zoom meeting, any of the kids who are chronically ill or have special needs, should that occur. Many of those kids obviously have their own camp, right? Diabetes camp, asthma camp. And I don't know if it's the COVID thing or what, many of our camp directors this year say they really don't have very many of those kinds of patients this year. I think people are still a little cautious if they have a special needs child, but we do offer that. And then because all of this started, back in fall of 2020, there's been a million changes since then. Obviously, vaccines, the difference in different recommendations in mask wearing, even the different recommendations about what to do in camp has changed from the official CDC guidelines. So we've just been keeping up with that and making sure that we're all on the same page, communicating regularly with the camp directors. Most of the work is going to be done before camp starts. Once camp gets underway, we feel like most of our work is done. Then it's simply just doctoring, and it's all the preparation ahead of time that really is very time consuming, which is one of the reasons why we charge a fee. It does take time. Okay, next slide. So what does this mean for you? Well, we're here in Chicago, and most of these camps are in Wisconsin and rural Wisconsin. And the way you get to rural Wisconsin is you go to the middle of nowhere and then hang a left. So they don't have a lot of options in terms of local places, but there's plenty of other places that have camps throughout the summer, and some of them may be close to you and some of your patients may be going there. I know that we got contacted by places in California that were more than willing to have us perform the same services, but we just couldn't afford to get camp license, state licenses for California, which is really what we needed to do to satisfy all of those camps' needs. It was kind of expensive. There was a time crunch, so we didn't think that was possible. Wisconsin has a very nice setup where, because we're in Illinois, because of the pandemic, because it's all telemedicine, there's an understanding. You just fill out a little form and that's it. Same for Minnesota. Same for some of the other states. So here in the Midwest, it really wasn't a big deal. If we wanted to go further away, like California, it is a big deal. So wherever you are, the Pacific Northwest, California, the Southwest, New England, the South, there's places around you, obviously, where kids go to camp, and you might be better positioned to, be the telemedicine doc. You gotta, as Russell said, you gotta make sure that the licensing thing and the liability is all set. Make sure your insurance, malpractice insurance carrier knows. Make sure you're not, skirting any rules about licenses. But once you get all those ducks in a row, and if you have time a year from now for next summer, then then you're good to go. And I got to tell you, so based on our experience last year, and again, it was limited because, as I said, there were only a few camps and they had a very brief period. Once camp starts, I'm going to breathe a big sigh of relief. I've been in charge of getting all of this set, and every day I feel like there's some sort of new crisis. But once camp starts, then I'm not going to worry about it anymore because that's the easy part. There's not that many calls, and the calls that do come in, it's pretty straightforward. It's a rash, it's poison ivy, it's a cold. Does he have strep or doesn't he have strep? It's pretty straightforward stuff. If it's not, then there's only so much that you can do with telemedicine, right? Kid was jumping on a trampoline, fell down, can't bear weight on his leg. His ankle's big and swollen, and looks like it might be broken. Okay, then he needs to go to the urgent care or ER that's close and get an X-ray. There's only so much I can do. So some of the more acute or more serious stuff is going to be handled by the urgent care or ER anyway. They know that. They just don't want to have to go for all the little stuff that we can handle, and we can handle very easily with telemedicine. The one thing I will say is this: we've been doing telemedicine with our patients like I said, for whatever it is, 15, 16 months. At the other end of the, at the other end of the call is a mother or father, well, almost assuredly is not a medical professional, who can barely take a pulse. I mean, we're lucky we get a temperature right. Now with camps, when we're doing this, we've got an experienced camp nurse on the other end who can, look in a kid's ears for me and tell me what she sees, who can listen to his lungs and say, this is what I hear, who can get a good blood pressure and all the other vitals. So this is almost easier than what we've been doing for the last 16 months in terms of assessing the patient. So it's great to have a medical professional on the other end, let me tell you. And so really that's about it. I would encourage you to think about this for next summer. It's a little late for this year, obviously. But it is another way to get your name out there. It's another way to bring in some revenue. And it's just a good use of telemedicine for these kids who, if you can keep them from going to some ER where they will get probably shoddy care because it's in the middle of nowhere, or a retail-based clinic, that it's not quite a medical home, but you're going to be providing better care than those other places, I guarantee it.
That's excellent. Thanks, Ruben. Thanks, Russell. So it's certainly utilize the chat if you want to put in questions. And we'll take this time to kind of talk a little bit about just telehealth in general. And summertime is a great opportunity to think about your strategy going forward. So for many folks, they see the COVID kind of going away, and some folks are hoping that telemedicine will go away and we can click our heels and kind of go back to the old way of doing things. And it's been interesting for me to look at kind of pre-pandemic, both Dr. Libby and Dr. Rakoba saw telemedicine coming before the pandemic. And now we begin to look at it again from the same lens pre-COVID, and all the challenges coming towards the medical home of turning patients into consumers and talk about convenience. So certainly the challenge for the medical home as patients go, as Dr. Libby mentioned, to retail clinics or non-pediatric urgent cares, and it's really all about convenience. So as we look forward, it's a question again: can technology, can virtual care, telemedicine, can it help the medical home meet that convenience, whether it's to a virtualist like Dr. Libby, or whether it's from a camp or others. So we'll talk a little bit about that. Next slide. So this is certainly how we were talking before the pandemic about just parent confidence in getting same day and same day care or advice for a sick child. So the real challenge for the medical home to meet that convenience, and many families not even calling the office with a fever and a sore throat. This is out of Mott Children's out of Michigan. Just trying to get email advice the same day or an appointment the same day. It was interesting. I was on with the Utah AAP earlier today, listening to, about the medical home and the specialist. And it was even fascinating from that standpoint when someone from the medical home wanted to get a subspecialty referral, the average time for scheduling that referral was 12 days. And the average for a patient being seen was, I think, almost 2 months in their Intermountain Healthcare. So it was pretty fascinating to think about how do we get patients connected to the medical home and those local relationships. So we have to begin to think about convenience and access to that medical home. Next slide. So this is also good data from Clear Triage and Barton Schmidt guidelines, kind of pre-pandemic and then post-pandemic, and kind of looking at the common, top 10 protocols that came into nurse call lines and nurse triage. So cough, colds, fever, diarrhea, vomiting without diarrhea were kind of the top hits. Certainly COVID took over many things as we went into the pandemic. But again, I think what we'll see, and why many are beginning to see, kind of cycling back to, cough and colds is kind of the leading reason that folks are looking for help, looking for advice from their pediatrician. And now more than ever, I think folks can recognize the value of virtual care and telemedicine, and how much we can do if it's, we can handle via the telephone, or what can we hand virtually, with these patients to make sure that cough and cold isn't a more significant respiratory illness. Next slide. And it's also interesting to look at disposition. So this was, again, data from within Clear Triage and, looking at nurses and outcomes of triage. And could we add telemedicine to, the nurse triage and disposition? And I think it also strikes, as we were preparing for this webinar, just talking about, what's the current state of parents and families when they're looking for help. Certainly there's, do I send them to the urgent care right away or the emergency department? Can we get re-engaged with second level physician triage? Can we impact certainly those emerging conditions? But it's also funny to think about, see within 3 days in the office or see them within 2 weeks. Just curious of folks that are listening in, how many families will wait 3 days for a minor visit or wait for a couple of weeks. My guess is that they probably, if they get a disposition like that, they probably automatically go somewhere else to be seen more quickly for these minor conditions. And much of that could be handled via telemedicine. So again, summertime telehealth initiatives, things to think about is how do we kind of move forward and get ready to integrate kind of telemedicine and virtual care into our practice, so that as we get busier and more sick visits come, are we ready to kind of handle that, or patients going to continue to migrate to other places? Next slide. So this is a good study from Dr. Schmidt, talking again about second level physician triage. And again, I think it's an opportunity. So, less than 8% of pediatric practices were doing second level physician triage. So nurses were referring patients on to other places if a child was sick or ill. And also it shows that, there have been more urgent calls, but overall calls have actually gone down. So we've seen it, urgent emergent referral rate actually has gone up. And so again, I think there's that opportunity for the pediatric medical home to utilize nurse triage, telemedicine, to really stay connected with the patients and to, see if we can reduce the number of ER visits and be able to handle more, through visualization. So I think that's an opportunity, as Dr. Libby pointed out, and certainly as we think about the conditions that Dr. Rakoba and Pediatrust will treat, via camps and the other things. It's more opportunity of how we keep kids connected to pediatricians in the medical home. Next slide. So again, this is kind of the pursuit of the value of connected care, and it's kind of fun to come back to some of these discussions because we used to talk about, is there value in and where is the value zone in telemedicine? And pre-COVID, there was a lot of feelings that telemedicine was bad medicine, or that there were more challenges and more risk rather than benefit. I think we have all seen now that we've kind of been thrown into the telemedicine world and the virtual care that there is a sweet spot in there. Dr. McConaughey is a pediatrician who recently retired from the University of Rochester, and this was done, 2015, and he had actually started down the path of telemedicine 10 years before. But it's kind of weighing the risk and the reward, the benefits, and how we can really find that value proposition for. Certainly we can handle many things via telephone, but there's times that you need visualization, and other times where you say, hey, they need to come into the office or they need to go on to the urgent care. So I like Dr. Libby's approach as a virtualist. He also refers patients into his office and he calls them offices. So, there are times, and I think we would all agree that telemedicine and virtual care is certainly not a way to replace all in-person care or all in-person visits, but gosh, could it be the virtual front door? Is it the way that we can get kids into the medical home and then triage them or care for them appropriately in the right place at the right time with the right provider? So again, I would encourage you to think about that as well. Next slide. So I think the other thing that you'll see coming kind of going forward is we've kind of been all focused on kind of a video visit and kind of real-time virtual visits. I think you'll see coming forward much more about remote patient monitoring and asynchronous visits or e-consults. So that ability to record a visit and then be able to send it on to a specialist, do a multidisciplinary visit, and think about it from both sides. We continue to have kind of a toe in both sides of the water here with the opportunity around fee for service and growth. So really thinking about, gosh, how do I improve access and improve convenience? But on the flip side, on the value-based side, gosh, how do I reduce costs and how do I get more patients to stay connected to the medical home? How do I use things that reduce, readmissions or admissions in general or ER visits? So there's lots of different things that are going to be coming. I mean, I think this is, what we've been through in the last 15 months is the tip of the iceberg of technology and virtual care. And I think the tip of the iceberg of how we can get the medical home back to the front and center and have patients and families reach out, to the pediatrician first and foremost, as opposed to kind of going elsewhere. So look for more coming when we start talking about virtual care and ways that it's not just a video visit, but actually adding in things like translators or virtual visits or doing consults from your office or things like that, and really an opportunity to kind of bring back those local networks of care. Next slide. So where's this headed? What is the future of patient office towards the medical home? And, we certainly talk about anytime pediatrics, but I think what Dr. Rakoba and Dr. Libby highlight is it's really about anytime and anywhere. So how do we keep patients connected into the medical home? How do we keep them engaged? How do we continue to improve, technology, and not technology towards it replacing anything, but technology actually as the connector. So, go on to the next slide. There's a couple different ways that we're thinking about this from a patient access standpoint, right? So we talk about telephone triage. We talk about reaching out to kids at camps or at schools. We talk about, having virtual lists, but how else do we improve kind of patient access to the medical home? So from an anytime standpoint, it's, one of the things we're really working on is how to mimic that in-person visit. So, the fact that a patient could come in and could communicate with the front desk, they could talk with the nurse, they could, share a picture of a rash, they could get scheduled later for an appointment, they could go right on to a virtual list. How do they stay connected in order to do that? So they can come in and check into the front desk. They can go to the nurse. The nurse can go to the physician or the clinician. Do we bring in a consultant? Do we bring in an interpreter? Those kind of things I think are really important kind of going forward where, the medical home becomes, another front door. You not only have the one where they walk through, but the one that they virtually come in as well. So I think we'll see more of that coming. The next slide. Third-party invite, I think, is another key piece. So if we have that ability, and I know we talked about this related to camps, and if you have a sick kid and they're off at camp, do you want to invite that parent? Or if they're homesick, do you not? But perhaps there's times that you need to bring a parent in, or you need to bring in a consultant, or you need to bring in somebody else into the visit. So being able to do those multi-person visits into a secure platform, and thinking about ways that you can do that is very important. So that third-party invite is a big piece, I think, going forward. Engaging multiple parents and the like. The next slide. And then I think, certainly from an anytime pediatric standpoint, we're very focused on how we can, decrease inequity, and language barriers are a gigantic piece of the puzzle. So we're adding live translation. So right now we have Spanish, but we're going to add many more languages, and we're rolling out in the next couple of weeks a Spanish version of our application, both on web and mobile. So more to come there. But again, I think this is all about patient access, increasing equity across the board, and figuring out all the barriers that we can overcome so that everybody has access to the pediatric medical home. Excellent. So finally, I'll turn it over to Darby, and she can talk a little bit about some of the other pieces of the puzzle around, telehealth and patient engagement. So many of us kind of wait for patients to call and schedule appointments, and we still hear from many that parents are unaware that they're offering virtual care, how to engage patients. We know that there's more coming related to behavioral health issues, mental health issues. So we have to begin to think about how we do more and more outreach to patients and families. So Darby, I'll turn it over to you so you can highlight some of those pieces for folks.
Great. Thank you, Dr. Connors. Hopefully, can you hear me okay? I know that I had some audio issues early on.
Yeah, much better.
Okay, great. So yeah, like Dr. Connors said, I just wanted to quickly touch on some best practices for engaging your patients this summer. Dr. Libby talked a little bit about how summertime can be a really great time to connect with your patients and a great time to take advantage of your telemedicine offering. So first, at Anytime Pediatrics, we always encourage our customers to promote their telemedicine offering in a variety of ways. So it's important to determine what the most effective way to communicate with your patients is. So this could be on your website, your social media channels, whether that's Facebook, Twitter, LinkedIn, through your on-hold and voicemail messaging, in-office posters and brochures, things like that. So you also may find that some parents have questions about telemedicine. They're wondering what visits are appropriate to conduct virtually, when their provider will be available for telemedicine, et cetera. So it's important to let them know and make it as easy as possible for them. So on the right, you can just see that's one example of a social media post that you could post for your patients. And as you may know, Anytime Premier customers can work with their customer success manager to customize and create branded marketing materials. And so those things can be in-office materials or social media graphics. You can update the informational landing page that you received when you were onboarded. So just reach out to your customer success manager to talk strategy on patient engagement and to learn a little bit more about what your options are. Next slide. So here are just some recent patient engagement materials that we've been sending out in our monthly newsletter. So on the left is just an informational postcard that included some QR codes to help your patients download the app, which I think will be great while your patients are on the go this summer and trying to connect virtually. And then on the right is just an informational graphic that you could use on social media, put on your website, specifically about mental health and telehealth, which was during our Mental Health Awareness Month. And finally, just another idea, if your practice does choose to be open for walk-in virtual visits on Anytime Pediatrics, that's definitely an important thing to market to your patients. So here's just an example, which our teams can help put all of this together for you and throw your logo on. But it's definitely important to share your hours that you'll be open and to remind patients to download the app or go to the web platform to request a visit with your practice. Now we'll have some time for some Q&A.
If I could, before we get to the Q&A, I just want to add one more thing. There's a lot of talk about, and I think Mick may have even used the same phrase, you're trying to make the telemedicine visit as good as or as close as an in-person office visit as possible. And I didn't realize this until we started doing telemedicine, but in some cases, a few cases, the telemedicine visit is actually better than an in-office visit. And I'll give you two examples. So one example is it's like it's like making a house call. You get to see what's going on in the house. Sometimes it's socially relevant. Sometimes it's relevant medically. People, for whatever reason, moms, and most of our parents who do this are moms, they like to walk around the house with the phone open, either to get a better place to talk or to find the kid that's running away from them, whatever. But you get to see a lot of what's going on in the house. And the mother will start off in the asthmatic kid's room where, look, it's hardwood floors and there's no knickknacks, there's no stuffed animals. But then as she's walking through the house, you realize, well, every other room's got shag carpeting, and there's where the kid spends most of his time in the basement or whatever. There's 8 million knickknacks. There's 8 million blankets and stuffed animals and whatnot. All this stuff that's setting off his asthma, and you see him nuzzling the dog, all the time. So it just gives you an idea of what's going on in the house, which you can't get obviously in the office. So it's helpful. The second thing is mental health. I get a lot of older teens, some young teens and young adults who, we see for a variety of reasons, and they're often reticent in the office, even when the parent's out of the room. But you get them when they're at college or at home in their bedroom, locked away in their bedroom, on the phone, talking to you. this is how they communicate with their friends. I know it's a phone, but they never talk on the phone with it as a phone. They, FaceTime or Snapchat or whatever. And so they seem to open up more when they're talking to the phone. The disembodied sort of care, I would think it's worse, but it's not. They seem to open up more because they're used to talking on a phone. I guess they don't feel as intimidated with you sitting, 6 feet away from them in an exam room. But I found them to be, very open, and I found the mental health visits, to go even better when they're on telemedicine than sometimes when they're in the office. So those are just two examples. But I think seeing what's happening in the home is sometimes, really a revelation. Wouldn't you say, Russell? I mean, have you had the same experience? Oh, you're on mute.
Sorry about that. My mute was on, of course. But yeah, no, it's a great opportunity, and I find that just the eye-to-eye engagement without the noise around us,
Right.
Without kids screaming, getting shots, without people coming into the room and interrupting, I find it's a much more effective interface. And the opportunity for other family members to come by and say hi, it's just, to me, it's been a very gratifying expansion, and I'm just astounded that between the technology and the moment we've been able to explore and actually evolve this way. That's been great. Yep.
Yeah, hopefully folks can certainly use a chat with questions. Ruben, I'm curious what you think is the future of the kind of the camp. Is that going to lead you all into schools or more camps, or where do you see that kind of going forward?
Well, I think more camps, first of all, because there's plenty of them out there. And I think as camps realize the services we can provide are probably just as good as having a doc right there on site. And the nice thing about it is the same doc for us all 8 weeks, and they're not going to get that up at camp. It's a doc a week, and then another week, then another week, then another week, and all that changing doesn't really make for a very stable sort of way to do things. So camps, and then I do think that there's other things that we are looking into. We did also establish a relationship with a high school this past year, but that was sort of different. We were actually in the high school. We hired somebody, and we had a couple of people who volunteered, but we staffed an on-site health clinic. But I could see us moving to a telemedicine sort of model where, we do the same thing with a variety of schools, and we can see them and diagnose them as long as the nurse that's at the school has the same equipment, analyzers, test kits, and whatnot. So yeah, I think going into the schools is probably our next venture.
Right. And Russell, have you seen an increase in kind of good old summertime coming back? Is this going to be the summer of rashes and poison ivy and otitis externa again, or where do you think I don't know, at least here in Tennessee, it's like the pressure valve has been released and people are running around like crazy and happy to be free of COVID. Will we head right back into where we normally were with more illness in the summertime, or what are you seeing so far?
Yeah, I think that it's going to be a standard summer. And once again, I think thinking about when people seek out that kind of care, if you get any feedback from those urgent cares or RVCs in your neighborhood, you'll find that the evening hours are the ones, and they're regular work day hours and not necessarily weekends, but those will happen as well. So yes, I've had a few insects, ticks, I've had a couple of Lyme diseases. Easy thing to look at because it's really not something that you're palpating. You're just getting a history and seeing a rash. And by the way, I do often make sure that my triage or appointment desk will ask them to take photographs, because the resolution on a photograph is generally better than what you can get using a video camera. Not that it is not variable, but it is but still a good thing to ask them to do so that you can really look at, and sometimes you can upload to your EMR. But nonetheless, yes, I think that we're going to have a pretty standard summer season, and all the kinds of things you normally see in summertime are going to be coming through there. So, the greatest thing I came to the conclusion of was that if I want to work the afternoon into the evening, I can provide a great service for my patients, expand and extend our office hours, and generate revenue with good care. That to me is something that we often will not accept, especially if we had to be in the office to do it. We can do this from the comfort of our own study or other setting where we are, and we can create that exclusive and encrypted environment that Anytime provides us, then we're in good shape.
And how often, Russell, are you referring patients on to the office? I know I mentioned to the folks that you and I discussed before that you now have an officist to back you up. How often is the officist coming into play with a telemedicine visit that needs an office visit, or
usually what it is, and there are two categories I would say that are most dramatic there. First of all, I've been in practice for years, and I feel pretty confident, comfortable with my clinical acumen and my ability to discern when someone has a problem that needs hands-on care right now. So if it's something where they have acute belly pain and it's clear to me that they have something more than just a little GI bug, it may be directly to the ER, and I can set up that triage for them there. If it's something with wheezing or something else that I just don't feel comfortable, I can adequately treat. And of course, through COVID, we weren't supposed to be using nebs in the office, so we ended up doing more of that on telemedicine, probably than was necessarily safe. But nonetheless, there are a few things. I would say that I may more often encounter the patient, give them a plan of care for the day, and then have them come into the office for follow-up in a day or two. And that way get both sides covered. If I'm feeling a little uncomfortable, well, could this be some, sort of hidden leukemia, and maybe they have a big spleen? I need somebody to feel that belly. The parent can't do that for me. That's when I'll say, let's see what happens over the next day or two. Come into the office. I'll send a note to my officist and just make sure that they know why I was concerned and wanted them to come in. So yeah, there are all kinds of nuances here, but it's the experience of using telemedicine that helps you devise and develop your own internal protocols so that you can feel that you are comfortably and safely providing the care that patients need.
Yeah, no, that's great. And Ruben, there's a question in the chat. How do you handle insurance copays for a camp telehealth visit?
Yeah, I saw that. So, that's a very good question. We haven't quite figured that part out yet entirely. The camps don't start here until like June 25th or something, whatever that Monday is, I think. At any rate, so what we try and do is we try and get a credit card on file for as many of these campers as we can, or at least the camp is trying to get a credit card on file. You got to remember, the vast majority of these kids we're not going to see, so we don't want to be collecting all this information just because we got to put it somewhere, and it's just a nightmare for us. But if the camp can get it, then if we've got a credit card on file, we'll just do that. We're not holding them up. We're not going to not see them if we don't, and then we will talk to the camp about figuring out some way that they collect it, and we just keep a record and pay us at the end of the month, whatever. Or if they can get the credit card on file, then we'll just bill the parent. But somehow it will get done. Either the camp is going to collect it, like I say, in those patients who don't have a credit card on file, or we'll have a credit card on file.
Yeah, actually, the camps we're working with in California are willing to put the credit card in for the family. They have that on file, just like if they went to the urgent care, the retail clinic. So it's interesting. It was, Ruben referred me out to some camps that were looking for help in California, and I've learned a lot of the challenges they face of just driving an hour and a half down the mountain, as they say, for a kiddo who's got pink eye or other minor conditions. So they really see the value add. And personally, I hope going forward we can get more kids at medical home, get them connected to the medical home, even at camp or at school. But it's interesting. One of the concerns I have, Ruben, is of, the practices I've talked to kind of try to find some coverage is opening the floodgates of sick visits. I know you only did a few camps last year. Was it a big burden to, with a few hundred kids on site? Were they lining up out the door with?
No, because you got to remember these camps. Well, maybe you're not familiar with them, but most of the time, the nurses that are at these camps have been there for years and years and years. And even if they're not, there's usually one nurse who's been there for a long time, and then, some new blood every year, sure. But they are pretty adept at figuring out who really needs to be seen and who just has a case of homesickness and they're complaining of this or that, and a little tender loving care, a little hand holding goes a long way. And which rashes are, that's just bug bites, put this on it, you're fine, versus that's a goofy one, I don't know, or that could be Lyme, or that could be this or that, we're going to need to call the doc. We didn't get as many calls as I thought we would last year. Now again, different time. There's going to be more people who we're going to get more COVID calls this year, even though everybody's been immunized, just because the camps are going to be fuller. They're going to get the regular colds and whatnot, and most of these kids can't be immunized, right? Because they're just not old enough yet. So we're going to get a lot of those calls, but that's going to be pretty easy to sort out. I don't think it's going to be of the floodgates, honestly. The nurses there keep a handle on things, and I think they're going to call us, very, very appropriately.
All right. Well, we're coming up on time. I'd like to thank Dr. Libby, Dr. Rakoba for their time, and Darby, thanks for setting everything up.